All right, let's crack open some serious knowledge here. You've
Yeah.
given us your revision notes on nephrotic syndrome, and consider this our mission, really, to
Okay.
take this stack of information and just distill the absolute most important insights.
Yeah, get right to the core of it.
Exactly. We're going on a deep dive, pull out the crucial details, make sense of the connections, and hopefully help you get a really clear picture of this condition fast.
Absolutely. And having these structured notes, well, it's gold, isn't it? It gives us a clear path.
Mm-hmm.
And our goal is just to walk that path with you, kind of highlighting the landmarks, giving some context.
Right.
We're going to cover everything laid out right here, sticking strictly to this material to really understand nephrotic syndrome, from definition right through to the complications.
Okay, perfect. So let's jump right in then. At its core, what exactly is nephrotic syndrome? What are the defining features we absolutely need to know?
So it's fundamentally a kidney disorder,
Okay.
specifically affecting the kidney's filtering units.
The glomeruli.
Precisely.
Hmm.
And the notes, they pinpoint 4 key characteristics that really define it. You need this specific pattern.
Okay, lay them on us. The 4.
First, and probably most central, is heavy proteinuria. We're talking about losing a lot of protein in the urine.
How much is a lot?
The notes specify more than 3.5 grams over 24 hours.
Wow, okay. That level of protein loss is significant.
Yeah.
And clinically, thinking about symptoms, this is where that phony urine thing comes in, right?
Exactly. That's often a visual clue for patients. So second is hypoalbuminemia.
Low albumin.
Yeah, low albumin, it's a key protein in the blood. The threshold here, typically less than 30 grams per liter. Sometimes the notes say even under 25.
Right. And losing all that protein from the blood, especially albumin, that has big knock-on effects. Which leads us to number 3.
Edema. Swelling.
Swelling, yeah. Usually starting where the legs, ankles, peripheral edema.
That's the typical starting point. It's because albumin, it sort of helps hold fluid within your blood vessels.
Right.
When it's low, that fluid just, leaks out into the surrounding tissues.
Okay. And the 4th key characteristic.
Hyperlipidemia. So elevated levels of fats like cholesterol in the blood.
Okay, so let's recap. The picture is a kidney problem,
Glomerular damage.
causing massive protein loss in the urine,
Proteinuria.
leading to low protein in the blood,
Hypoalbuminemia.
which causes the swelling,
Edema.
and you often see high fats alongside it. Hyperlipidemia.
You got it. That's the tetrad. And the underlying issue driving all of this, as the notes describe, is damage to those kidney filters, the glomeruli.
The linky sieve.
That's a great analogy. They're supposed to keep big things like protein in the blood, but when they're damaged, the holes get too big.
So proteins, especially albumin, just slip right through.
Exactly, into the urine, in excessive amount. The notes also add that along with these core features, you often see other consequences or associations. Things like coagulation abnormalities.
Clotting problems.
Yeah, a reduction in overall kidney function and sometimes immunological issues too.
That makes perfect sense. It's like a cascade effect from that initial kidney damage.
Right.
Now, a really crucial point that was raised early on in the notes is that while often the exact reason isn't clear, it's idiopathic, right?
Right, often is.
The causes that we can identify differ quite a bit depending on a person's age. That feels like a really high-yield piece of info for anyone listening.
It absolutely is. Huge point. And that takes us neatly into the etiology, what causes this glomerular damage in the first place. The sources break this down neatly into primary and secondary causes.
Okay, so primary means the problem starts in the kidney itself?
Yeah.
Like it's a kidney-specific disease?
Correct. Problems with the glomeruli themselves. The key primary causes highlighted are minimal change glomerular disease.
The one common in children.
Exactly. Noted as very common in kids. Then in adults, the more common primary culprits are focal segmental glomerulosclerosis, FSGS, and membranous nephropathy.
Okay.
Membranoproliferative glomerulonephritis is also mentioned, affecting both children and young adults.
Right. And then the secondary causes, this is where it connects to other stuff going on in the body that ends up affecting the kidneys. The lists look pretty long.
It is, and it's important because it shows nephrotic syndrome isn't always just about the kidney in isolation.
So what are some big categories here?
Well, the notes group them nicely. You've got systemic problems like infections, bacterial, viral, parasitic are listed.
Okay.
Immunological or inflammatory conditions are key. Think lupus, rheumatoid arthritis, prime examples.
Right. Autoimmune stuff.
Exactly. Metabolic diseases are significant too, notably diabetes and amyloidosis. Then there are inherited causes like Alport syndrome, certain malignant diseases like multiple myeloma,
Myeloma, okay.
and even specific drugs. The notes list NSAIDs and captopril.
Wow, NSIs are so common. That's really worth remembering. And I saw insect stings on that list too. That seems random.
It just shows how diverse the triggers can potentially be.
Mhm.
Also on that secondary list are pregnancy-related issues, specifically pre-eclampsia and even transplant rejection.
So it really underscores that this can be a sign of something much bigger happening systemically.
Absolutely. Which leads nicely into risk factors. Thinking about susceptibility, are there specific things mentioned that make someone more likely to develop this?
Yeah, what makes someone more at risk?
Well, unsurprisingly, the risk factors described really mirror the causes we just talked about.
Makes sense.
So, a personal or family history of kidney disease is a risk that links to inherited causes or just underlying kidney vulnerabilities.
Okay.
Having autoimmune diseases like lupus or RA obviously increases risk because they are listed secondary causes.
Right.
Certain infections, same logic. And the use of specific drugs, like those NSAIDs we mentioned, it all ties back to that list of secondary causes.
So if someone listening has, say, a history of uncontrolled diabetes or they're on certain long-term meds, a clinician would be sort of more attuned to the possibility of nephrotic syndrome if they show up with swelling or, other symptoms.
Precisely. Knowing these potential triggers and risk factors helps guide that initial suspicion and points you towards the right investigations.
Okay. Let's maybe just quickly revisit the pathophysiology. How does this actually play out inside the body? We use the leaky filter analogy, but what's the core mechanism?
Yeah, the central problem, as we touched on, is that glomerular damage leading to increased permeability. The filter gets leaky.
Right.
So the kidneys filters, they're meant to be selective sieves, right?
Yeah.
Let small waste out, keep the big important stuff like proteins in the blood.
But when the filter's damaged, the holes get bigger.
Essentially, yes.
Mm-hmm.
Larger pores or actual breaks in that filtration barrier. This allows those larger proteins, especially albumin, to just escape from the bloodstream and spill out into the urine. Way too much.
And that massive protein loss, that's the defining event.
It is. Losing so much protein, especially albumin, directly causes the low blood protein level, the hypoalbuminemia.
Which then causes the swelling, the edema.
Yes, because there isn't enough protein, specifically albumin, in the blood vessels to exert oncotic pressure and hold fluid inside them, so it leaks out into tissues, causing edema, ascites, pleural effusions.
Okay. And the high fats, the hyperlipidemia.
That's a more complex consequence, thought to be related to the liver trying to compensate for the protein loss, but it's part of that cascade. It's all a chain reaction starting with that damaged filter.
And the notes stress that the specific way the damage happens, the exact pathophysiology, can vary depending on the underlying cause, right? Which is why finding the cause is so vital for treatment.
Exactly right. The mechanism in minimal change disease is very different from, say, diabetic nephropathy, even though both can lead to nephrotic syndrome.
Okay. So given these hallmark features, heavy protein loss, swelling, what other conditions might, look similar, what else could be on the differential diagnosis list?
Yeah, differentials are crucial. You need to rule out mimics. The notes mention key conditions like acute glomerulonephritis, chronic kidney disease, and diabetic nephropathy.
And these can also involve protein in the urine or some swelling?
They absolutely can, yes. But the distinguishing factor, which the notes emphasize, is often the specific combination and, crucially, the severity of the features.
Oh, right.
Nephrotic syndrome is defined by that heavy proteinuria, the significant hypoalbuminemia, plus the edema and hyperlipidemia. Other conditions might have some protein loss or some swelling, but the whole package and the sheer magnitude of these findings often points more definitively towards nephrotic syndrome.
Got it. So it's not just a bit of protein, it's a really pronounced pattern. Okay, let's get a sense of scale. How common is this condition? What's the epidemiology look like?
Well, the numbers give some context, though the notes do mention specific UK data can be a bit limited.
Okay.
The estimated annual incidence for adults in the UK is somewhere around 2 to 7 cases per 100,000 people.
Relatively uncommon overall.
Relatively, yeah. Globally, it's estimated around 3 per 100,000 for adults. For children globally, the incidence seems to vary a bit more, maybe 2 to almost 17 cases per 100,000. But the really crucial takeaway from the epidemiology section, again, reinforces that point we made earlier about age and cause.
That huge difference between kids and adults.
Exactly. In adults, something like 80–90% of cases are idiopathic, meaning the cause isn't obvious, or the known primary causes are typically FSGS and membranous nephropathy. And secondary causes like type 2 diabetes and SLE are also common in adults.
But in kids,
But in children, minimal change disease just dominates, accounts for a massive 70–90% of cases.
wow, that is a dramatic difference. Minimal change is still seen in adults, yeah.
It is, but only accounts for maybe 10–25% of adult cases. So this age distinction is clearly a defining epidemiological feature.
And that obviously has big implications for how you'd approach diagnosis and treatment based on age.
Absolutely. It significantly influences the likely diagnosis and that initial management approach, especially the question of whether you need a biopsy up front.
Right, so putting ourselves in the shoes of someone actually experiencing this.
Yeah.
What does it look and feel like? What are the clinical features listed in the notes?
Okay, so the most obvious, the most common presentation is that new onset swelling. Usually starts in the lower extremities, legs, ankles.
Peripheral edema.
Right. And the notes detail how this edema can become much more widespread as things get more severe.
Spreading up the body. To the abdomen, maybe?
Yeah, potentially leading to ascites fluid in the abdomen and also periorbital edema, that's swelling around the eyes.
Okay, and all that fluid buildup obviously means
Significant weight gain, often quite rapid. Other symptoms people frequently report are fatigue, just feeling wiped out, sometimes decreased urine output, oliguria, and shortness of breath, especially with exertional dyspnea.
And that's due to fluid around the lungs, pleural effusion.
That's often the cause, yeah. Other symptoms listed include hypertension, which can develop, discomfort just from the swelling itself, abdominal or genital discomfort, dizziness, abdominal cramps.
The notes also mention signs pointing towards complications, like infections or clots.
Yes, exactly. So things like fever, nausea, vomiting could suggest an infection. Pain, swelling, redness in a limb might point towards a DVT, a blood clot. And in children specifically, growth issues or delayed puberty can be features.
Okay. And what about on physical examination? What would a clinician be looking for?
Well, obviously the edema itself, checking its extent, listening to the chest for signs of pleural effusion causing breathlessness. But interestingly, despite all that swelling, someone can actually show signs of hypovolemia, low blood volume within the vessels.
Ah, the paradox we mentioned earlier. Fluids in the tissues, not circulating properly. How would that manifest?
The notes list things like a fast heart rate tachycardia, cold hands and feet, cold peripheries, and that low urine output, oliguria, which we already mentioned as a symptom.
So fast heart rate, cold extremities, low urine output, despite being swollen elsewhere. That's a key clinical pearl. Feels counterintuitive at first.
It does. Other signs can include those related to the hyperlipidemia, the high fats. Sometimes you might see xanthomata or xanthelasmata, which are these visible fatty deposits under the skin.
Okay.
And of course, you'd be looking for any signs pointing to a potential secondary cause, like a rash or joint swelling, suggesting lupus, for instance.
And there was that one really specific kind of memorable sign mentioned in the notes.
Ah, yes, the fingernails.
Murky's lines.
Murky's lines, those transverse white lines across the nails, they're highly associated with significant hypoalbuminemia, a classic textbook sign, really.
Okay, so you see this pattern of symptoms, these signs. How do you actually confirm the diagnosis and figure out the underlying cause? What investigations are key?
Right, the investigations are crucial. They aim to, one, confirm those core diagnostic criteria we talked about, and two, search for the underlying cause and any complications. Urine tests are absolutely foundational.
Makes sense. You need to quantify that protein loss.
Exactly. So a 24-hour urine collection, or more commonly now, a spot urine protein to creatinine ratio, tells you how much protein is being lost. Confirms the heavy proteinuria.
Okay. Anything else in the urine?
The notes also mention looking at the urine sediment under a microscope for cellular casts like fatty casts or red blood cell casts. These can sometimes give clues about the specific type of kidney damage happening.
Right. And then blood tests to check the other core features.
Absolutely. Serum albumin, obviously, to confirm the low blood protein. Urea and electrolytes to check overall kidney function. Lipid levels to assess the hyperlipidemia. Standard stuff like liver function tests, too.
What about tests to hunt for those secondary causes?
Yeah, that's key. The notes list things like serum light chains and protein electrophoresis, especially if you're suspecting something like multiple myeloma.
Okay.
Tests for infections like HIV, complement levels, and autoantibodies like ANA, anti-nuclear antibody, if you're thinking about autoimmune conditions like lupus.
And imaging. I saw chest X-ray and ultrasound mentioned.
Yep. Chest X-ray, mainly to look for pleural effusion. And a renal or abdominal ultrasound is important to assess the kidney size and structure, check for any blockages, and can also help guide a biopsy if needed.
Right, the biopsy. The notes seem to really emphasize the renal biopsy. Why is that often so vital?
It often is, especially in adults. The notes state it's needed if the diagnosis isn't crystal clear, or specifically in adults, because that range of potential causes, particularly the primary glomerular diseases, is just so much wider than in children.
Okay.
The biopsy lets pathologists actually look at the kidney tissue under a microscope. It allows them to identify the exact type of glomerular damage.
And knowing that specific type is critical
Because the specific type of damage often dictates the specific treatment strategy. It also helps predict the likely prognosis, how things might go long term.
But there was that exception for children you mentioned earlier.
Yes, exactly. Because minimal change disease is so common in children, and it usually responds really well to initial steroid therapy. A renal biopsy is often not needed initially in children who present typically for minimal change disease. You usually try treatment first. Only if they don't respond or if the presentation is unusual would you then consider a biopsy in a child. That's a major difference in approach based purely on age.
Got it. And the investigations would also cover checking for potential complications like that clotting risk.
Correct. So a full blood count, checking for anemia, and a coagulation screen would definitely be part of the standard workup.
Okay, so once it's all diagnosed, cause identified hopefully, what's the management plan? What does treatment actually involve?
So management has several key goals as outlined in the notes. You want to reduce that proteinuria.
Stop the leak.
Exactly.
Okay.
Control blood pressure, manage the edema, the swelling, and crucially, treat the underlying cause if you've identified one and if it's treatable.
And the mainstay medications often involve hitting the immune system, right? Especially for those primary causes.
That's often the case, yes. Particularly corticosteroids, they're frequently the first-line treatment, especially for things like minimal change disease.
Okay.
For cases that don't respond or for specific underlying diagnoses identified on biopsy, other immunosuppressants come into play. The notes list examples like cyclophosphamide, mycophenolate mofetil, calcineurin inhibitors like tacrolimus or rituximab.
And managing blood pressure isn't just about blood pressure, it helps the kidney too.
Absolutely critical. Hypertension control is vital. And the notes specifically highlight using ACE inhibitors or ARB's angiotensin receptor blockers.
Why those specifically?
Because not only do they lower blood pressure, they also have a direct effect on reducing protein loss in the urine. That's a really key therapeutic benefit in nephrotic syndrome. Double whammy.
Nice. And what about tackling those complications we talked about, the high fats, the clots?
Yep, management includes addressing those directly. So statins for the hyperlipidemia. For patients at high risk of blood clots, or obviously if a clot actually occurs, anticoagulants are necessary.
And what about giving IV albumin back, if it's so low?
That's mentioned. Intravenous albumin might be considered for severe hypoalbuminemia, especially if someone is very volume depleted. But the notes indicate this approach is kind of variable, maybe more for symptomatic relief in specific situations rather than routine treatment.
Okay. What about things beyond prescribing? Any lifestyle or dietary advice?
Oh, definitely. Non-prescribing management is vital. Dietary sodium salt restriction and often fluid restriction are key to managing the edema.
Right. Less fluid and less swelling.
Exactly. For milder swelling, just simple things like elevating the legs when sitting, maybe using compression stockings can help. And daily weight checks are really important. They help monitor fluid balance and see how well diuretics are working if they're being used.
Any other important points? Vaccinations?
Yes, good point. Due to the increased risk of infection, both from the disease and potentially the immunosuppressive treatment, vaccines are advised, particularly the pneumococcal vaccine and the chickenpox vaccine for children if they haven't had it or been vaccinated.
And is this typically managed by a GP, or do you need a specialist?
The notes are pretty clear on this. Urgent referral to a nephrologist, a kidney specialist, is essential for proper investigation, diagnosis, and ongoing management.
Makes sense. Are there times when someone needs to be admitted to hospital straight away?
Yes. The notes list indications for acute hospital admission. Things like really severe refractory edema, developing serious complications like a blood clot or severe infection, maybe inability to comply with treatment at home, or if there are features suggesting nephritic syndrome alongside the nephrotic picture.
Okay, so finally let's look ahead. What's the prognosis? What's the likely outlook for someone diagnosed with nephrotic syndrome?
Well, the notes make it very clear that the prognosis varies hugely. It really depends primarily on the underlying cause and how well the condition responds to the treatment given.
So some causes have a much better outlook than others.
Dramatically so. Minimal change disease, especially in children, generally has a very favorable outlook. Many achieve complete remission, meaning the protein leak stops, although relapses can definitely happen down the line.
But other types might not be so straightforward.
Unfortunately, yes. More severe cases or certain primary diseases like FSGS, particularly if they don't respond well to steroids, can progress over time to chronic kidney disease, CKD, or even end-stage renal failure, ESRF.
Requiring dialysis or transplant eventually.
Potentially, yes.
Right.
And there was that specific statistic mentioned for FSGS in adults.
Yeah, I remember seeing that.
The notes state that about 50% of adults with idiopathic FSGS may progress to ESRD within 5 to 10 years. That really brings home the potential seriousness and the variability depending on the specific type.
That's quite sobering. But treatment has improved things overall.
Oh, absolutely. The historical note mentioned that the introduction of corticosteroids dramatically improved survival rates compared to the pre-steroid era. Treatment makes a huge difference.
Okay, and just to quickly recap those potential complications one last time. What are the main things we need to be aware of, and why do they happen?
Sure. So the complications are really direct consequences of the syndrome's effects. Infections are common. That's due to weakened immunity, partly from losing immunoglobulins in the urine, partly from the immunosuppressive treatments used.
Okay.
Blood clots, venous thromboembolism, VTE, including DVT in the legs, and potentially renal vein thrombosis, clots in the kidney veins. That's a high risk because the condition causes a hypercoagulable state. The blood is stickier.
Right, clotting risk is a big one.
Huge one. Acute kidney injury can happen, especially if volume depletion gets severe. And then the big long-term one is progression to chronic kidney disease, or ESRF, particularly with steroid-resistant types or certain underlying causes like amyloidosis or advanced diabetic nephropathy.
And there were also issues with bones and thyroid mentioned.
Yes, less common maybe, but bone conditions like osteitis, fibrosis cystica, or osteomalacia can occur due to changes in calcium and vitamin D metabolism, partly related to protein loss. And the syndrome can sometimes trigger or worsen hyperthyroidism. Anemia can also occur, partly from losing iron-binding proteins or erythropoietin factors in the urine.
Wow, okay. So we've really taken a deep dive into nephrotic syndrome, all based on the notes you shared. We've covered what it is, that huge range of potential causes,
Primary and secondary, yeah.
how it actually disrupts the body, the pathophysiology, what symptoms and signs might make you concerned, the key investigations needed to pin down the diagnosis and find the cause.
Including that crucial role of biopsy, especially in adults.
Right, and then how it's managed, meds, diet, the lot, and finally the potential prognosis and those serious complications to watch out for.
It really is a condition that highlights just how intricate the kidneys are, doesn't it? And how their dysfunction can ripple right through the body. Understanding that specific underlying cause is just so paramount as it really guides everything that follows.
Absolutely. Thinking back over everything we've covered based on your notes, what's the one thing that really stands out to you?
That's a good question, I think. Considering how much the prognosis and the specific management hinges on identifying that precise underlying glomerular disease. The massive difference between treating minimal change in a child versus managing, say, FSGS in an adult.
Yeah.
It really makes you consider just how vital that initial diagnostic step can be, sometimes involving an invasive procedure like the renal biopsy. How critical is getting that specific pathological diagnosis right at the start to really shape the entire journey and outcome for a patient? It's a key decision point.
That's a great point to reflect on. Well, thank you so much for sharing your notes and allowing us to explore this topic with you today.
My pleasure.
If you, listening, are looking for more high-yield information like this, perhaps as you continue your own learning journey or revision, you might find some really useful resources over at pastthemsra.com.
And don't forget, for additional free resources, you can always check out freemsra.com as well.
Excellent. Well, until our next deep dive,